Okay, got it. Yeah. Good evening, participants and delegates. Thank you for joining Shield Connect today. So today we have Dr. Dahila Bharath, and ma'am is going to take topic practical approach to ovulatory dysfunction in infertility, series 1. So before we start with the session, let me give a quick introduction of our page Shield Connect. So this is our page Shield Connect. We have recently won 5 awards in women's health category. And these are the various sections available in our blogs. Like first is the blog section. You can find all the blogs written by the eminent speakers and doctors. Then we have a webinar section where you can find upcoming webinars and past webinars. So in upcoming webinars, you can see all the webinars that are going to be conducted on this page. So if you click on today's webinar, if you click on see more, you will able to see the webinar on this section. And in the comment section, participants, you can post your queries so we can have a Q&A session at the end of our webinar with the speaker of the day. Then we have a past webinar section. You just have to register through email ID and you can see all the webinars that we have conducted in the past. Then this is our leader section page where you can find all the speakers who are connected with Shield Connect. You can go through their profile in detail. We have around 26 pages of profile of key opinion leaders. Then we have awareness pages like PCOS awareness page, GDM, COVID-19, immune booster, menopause, thyroid awareness page. So if you click on any one of the awareness page, you will be able to find details regarding those topics. Then we also have a special day pages. Similarly, like awareness pages, you can click on the day related page. Like if you click on hypertension day, you will find all the videos regarding the hypertension. Now, let me give a quick introduction of our speaker for the day. So Dr. Dahila Bharath, ma'am has done MD, DGO, ART in obstetric and gynecology from Madras Medical College. And ma'am is a consultant and managing co-director of Queen's Fertility Center in Tirunelveli Valley in Tamil Nadu. And ma'am is also got a prestigious award of A.L. Mudaliar Award in Obstetrics and Gynecology. Ma'am is member of FOXY, ISAR, FPS and IAG. And ma'am is consultant fertility and expertise in IVF for 20 years. So ma'am, we are glad to have you on our platform and I will hand over the session to you, ma'am. Thank you, ma'am.
Thank you. Thank you for the nice words. Today, start sharing my screen. So today, thank you, Shield, for being the academic partner. So today, actually, we are going to discuss about ovulatory dysfunction. This series is not going to be anything of much of theory. It's going to be a practical discussion because we all know what is ovulatory dysfunction, the causes, the treatment, as everyone is well versed with it. But how to approach? So the common reasons for ovulatory dysfunction which we face in our clinical practice, and how do we approach them, and how do we find the right treatment for that is going to be the actual webinars this series. So first, since this is the first day of the series, we'll have a general idea of the causes for ovulatory dysfunction. Then we'll focus on one per series. So what is ovulatory dysfunction? So it means the ovary has failed to work. What is the function of the ovary? Ovulation. So it has failed to work means there is some ovulatory dysfunction. It is not able to ovulate. And there is a discrepancy between the uterus and the ovary and you don't get the regular periods. So we call it as ovulatory dysfunction when for the group of disorders in which the ovulation fails to occur or it occurs on an infrequent basis. Infrequent in the sense it is less than 9 periods per year. and you have a regular cycles, it is around 12 to 13 periods per year. When it comes to less than 9 menses, it creates a check there. That means there is some failure in ovulation. So what are the symptoms? A couple presenting in the OPD, the female complains of, I don't get my periods regularly. I have an absent in the sense don't get my periods without tablets, or irregular menses. It could be once in 2 months or once in 3 months they're getting the periods. And even if they get the periods, they do not have any premenstrual symptoms like breast tenderness or abdominal bloating or any moodiness which are associated with the ovulatory signs due to progesterone. So when the female presents like this, the first thing strikes in your mind is you have some problem with the ovulation. That is some ovulatory dysfunction. So we are looking on to the causes. So what all strike your mind? The first what should come into our mind is a polycystic ovarian syndrome, which is an endemic here actually. And another cause could be a too low body weight. It could be a lean PCOS. Always think of a lean PCOS as tuberculous patient when they have a too low body weight. And extremes, anything extreme is bad. It could lead to ovulatory dysfunction. The ovaries don't tolerate anything extreme. So it could be an exercise, or it could be high levels of stress, or extremes of hormones, or extremes of ovarian reserve. It could be a prolactin being too high, the thyroid being too low, high levels of stress, or very low, the follicle count, the ovarian reserve falling. All these mainly lead to the ovulatory dysfunction. So any patient with irregular menses, immediately all of these should come into our mind, but the first focus should be on PCOS. If it is ruled out, it go to the other causes. So coming to the etiology, once we know the etiologies, then every series we can focus on 1 or 2 etiologies and discuss that. So first should be, I told you, it should be the polycystic ovarian syndrome. The ovaries actually do not ovulate, or ovulate on a very infrequent basis. So you have irregular menstruation. Then it could be the hyperprolactinemia could be another cause. The high prolactin levels actually they cause lowering of the follicular stimulating hormone and the luteinizing hormone. So there is no folliculogenesis, and you have infrequent periods. And another one is a hypothalamic amenorrhea. That is, the hypothalamus is not directly affected by any tumors or any trauma. It could be because of stress or extremes of conditions which cause some disturbance in the hormonal milieu. Yeah, or it could be eating disorder like anorexia nervosa, also causing problem with the hormones leading to deficient folliculogenesis and anovulation. So I said extremes of stress, any extreme doesn't hold good for the ovary. So any extreme, the hypothalamus, it could be emotional or it could be a physical stress, but there's no underlying pathology in the hypothalamus. These stress lead to infrequent ovulation. And the endocrine problems, we need to focus on the endocrine problems. It is either the thyroid or the prolactin. So the thyroid, either the hyper or hypothyroid, both could have some problems with the ovulation. Drugs like hormonal drugs, hormones, or antidepressants. Actually, these drugs do have some impact on the ovulatory condition of the ovaries. And diminished ovarian reserve, because we know at birth you have this much number of follicles, and around by puberty, because of the atrasias, they start declining, and around the age of 37 you have started getting the low ovarian reserve, and by 45 almost the ovarian reserve is completely gone. So when the ovaries are getting depleted of the follicles, start getting infrequent ovulations and irregular periods. So the one we call it as, when you call it as premature ovarian failure. So ovaries fail to function because of very low number of follicles before the age of 40. Before the age of 40 years, we call it as premature ovarian failure. So finally, we have seen a number of causes for infrequent ovulation. See, these causes all finally focus into only one thing. That is, the final outcome is anovulation. The ovaries do not actually respond to the follicle stimulating hormone, or they have some resistance to these hormones, and finally they do not ovulate. So anovulation becomes the actual real problem for the of this ovulatory dysfunction. So now how do we deal with the anovulation? Or depending on the cause, there is, though the finally we go for the induction and do other induction with the drugs and go for a time 6 or a IUI or finally IVF, the actual treatment, the basic treatment varies with the cause of ovulatory dysfunction. So if it is a PCOS, you go through one way, and if it is a hormonal problem, you go accordingly. Or if it is a stress or it's a poor ovarian reserve, the treatment varies. So WORKUP. So now we have diagnosed that the patient has got a ovulatory dysfunction. She's not ovulating properly. So that could be the main reason for their infertility. So how do you go for a workup? I always put up a transvaginal ultrasound. Transvaginal ultrasound is the gold standard, the gold standard for diagnosing any ovulatory pathologies. So you can look into the ovaries, uterus, and the organs associated as with the ovaries, and look into the pathology. You can ovaries, you look for the polycystic ovaries, or look for a diminished ovarian reserve, or any follicular or luteal persistent cyst which is not which is delaying the ovulation, or any endometriomas which causes a luteinized unruptured follicle. That also could be a cause of anovulation. So all these can be found with the transvaginal ultrasound. So once the ultrasound is done, now we have to go into the hormonal evaluation. We have already seen that TSH, doing a thyroid stimulating hormone, is must. Prolactin is must. The AMH, the anti-Mullerian hormone, is very, very important diagnostic criteria to differentiate polycystic ovary from the poor ovarian reserve. The FSH, LH, estradiol, very important criteria in the sense to differentiate the poor reserve, as well as the PCOS, and the LH level plays a very important role to know whether you have a resistant PCOS or whether you'll respond with drugs or need surgery. And progesterone, the final hormone produced after ovulation, showing that if it is less than 3 nanogram per ml, then it shows that is the patient, the female has not ovulated. So once the scan is done, the hormonal evaluation done, then we go for, now today after evaluation, we are going to focus into one topic per series. So today's topic focus will be on PCOS. So how do you approach a couple with PCOS? Polycystic ovarian syndrome, I said it's very endemic, so we need to not to just start on drugs. We're not going to talk about the theory of PCOS because it is well known. So how to approach a couple with PCOS and how to help them to get pregnant. So first I focus on any couple with PCOS. I focus on lifestyle measures. Lifestyle measures is very, very important. Unless these lifestyle measures are not maintained, we are not going to get a fruitful outcome with induction or any other methods of ART. So always go for a holistic approach. Holistic in the sense, I mean, put them on the right diet, do the right exercise, and help them with drugs. Unless the diet and exercise is not done, I do not start them with drugs. Diet and exercise and maintaining the lifestyle measures are the most important approach to PCOS. Once she has put at least 5 to 10% of body weight in case of obese PCOS. Once she has lost only 5 to 10% of body weight, then only I start the induction or put them on drugs like ovulation induction drugs. Once they have started losing at least 5 kg of body weight, then I put them on insulin sensitizers and then start with the ovulation induction. So you have to teach the patient the right diet, the PCOS, couple the right diet and the right type of exercise should be taught so that they should be motivated. They should be motivated to do this. So the looking at the what is the diet you prescribe. It is a low carbohydrate, the high protein diet. Very important. You should go, you can have carbohydrates, you can have proteins, you can have vitamin, mineral, you can have everything, but your diet should be balanced with high protein and low carbohydrate. So when you go for animal-based protein, say per protein per 100 grams, you can go for the eggs or the flesh. All should be, what I advise is everything should be a boiled and nothing should be fried. Should take it as a boiled one. You can go for the plant-based protein, the chickpeas, and you go for the rice. The brown rice is a better one. The quinoa, the peanut butters, the nuts, the vegetables and fruits. The broccoli and avocado contains a higher amount of proteins. So ask them according to their status, like how much they can afford. You cannot expect a couple from a poor family to have broccolis and avocados, but you can ask them to take chickpeas, ground nuts, mushrooms, and all that along with eggs and fish. Those who are affordable can go for quinoa, nuts, and the other costlier type of proteins. But everything is protein. Even groundnut and chickpeas also work same as badams and almonds and cashews. So maintain them on a high protein diet and ask them to go for a low carbohydrate diet. So you can see on top what are the foods most people eat. So these are vegetables, and along with that, they go for the maida, the parota, the fried items, biscuits, cookies, and potatoes. All these are actually the food most people take. When you put them on a low carbohydrate diet, see what are all getting filtered. So the potatoes, the parathas, and what is the French fry, everything is getting filtered. So you can go for the vegetables, the tomatoes, you can go for egg, you can go for nuts, you can go for the flesh, all the boiled flesh. So these are the diets you have to prescribe to the people. So tips for diet. So skipping breakfast is main culprit. Ask them to take plenty of water. As I already told, go put them on a low carbohydrate, high protein diet. Ask them to take fruits, vegetables in plenty. And no fried and only boiled food is a criteria. Once you explain to them the importance of this diet and give them a diet chart and keep motivating them and monitor them at least once in 15 days, surely they actually get into the track of PCOS treatment. So now, do you know the 5 culprits of PCOS? Only if we know the culprits of PCOS, you'll be able to correct the causes and then put them on ovulation induction and get a very higher success rate within a short period of time. So we already know that PCOS is a lifestyle disease. So lifestyle disease, you have to go for lifestyle modifications. So culprit number 1, skipping breakfast. So most of them, the office goers, the school going children, actually the PCOS starts with adolescents, we know. I know I usually see the PCOS starting at least 2 to 3 years of post puberty. That is the time they enter into either 11th standard, 12th standard, or going to college, staying in hostel. All this, they keep skipping the breakfast, or even office going women. And I also see home workers skipping breakfast. That is, they have their breakfast very late, around 10:30, 11:30. And that is not considered as breakfast. You have to take your breakfast before 9 o'clock. Whatever you take, Very important. Breakfast is a very important meal. Once you skip the breakfast, the fats keep accumulating. The insulin resistance actually high with skipping breakfast, and you go for a high luteinizing hormone levels, which is very much seen in PCOS, and they start developing PCOS. So how should you eat? You have to eat breakfast like a king. It's an old known proverb. Everybody knows this. Lunch like a prince, and as the time comes, as you come to dawn, like dinner like a pauper. That is, keep your diet in such a way that you take most of the balance, very good meal after a long fast in the night, take it well balanced. Then in between a lunch with high proteins, low carbohydrate, and in between a lot of water, and dinner you restrict very much to a small amount of either pulses or vegetables, cut salads and fruits. So culprit number 2, most of them do not drink water. They either they have some just a half glass of water or 1 glass of water just after breakfast or lunch or dinner. That is the time they take water. They do not take water as such. So it is a very wrong thing. Water is mantra actually. You have to take at least 3 liters, 2.5 to 3 liters of water at least a day, which helps to replenish. And water is a very important criteria. It actually replenishes the hormonal, it settles, stabilizes the hormonal milieu in our body. So water intake is very, very important. Stress them to take water and teach them the importance of proper food timings. Most of them do not take. They have their breakfast around 10:30, 11, and lunch after 3:30, 4 o'clock, and night dinner just before going to bed around 10:30, 11. That is not the right thing to do. As then the breakfast, once you take it before 9 o'clock, it is called breakfast, has to be taken, and rather than taking the food as a bulk at one like a lunch or any huge volumes of huge amount of food as a dinner, better to take it as a split meals. Every 2 to 3 hours you take some amount of protein, some amount of vegetables, and some 2 types of fruits, or take water in between, take some boiled pulses, and maintain your food timings every day. Every day try to maintain the regular timings for food. And culprit number 4 is the junk food. Now these are the fast food, the delicious meal. It's meant to be a delicious meal nowadays by this generation, but it is not so. These are the foods which raise our glycemic index. They have very high glycemic index, these foods. They raise the blood sugar levels in our body very quickly, and leading to deplete the insulin, so that more amount of insulin needed to bring down the blood sugar levels, keep depleting the insulin, and finally insulin resistance development, leading to PCOS and diabetes. Culprit number 4 is inadequate sleep. No, because of the I think the work pattern. Most of them have sometimes night shifts, or it's a long time work, that is a work up to 11, 12. After that, they have their dinner, then go to sleep and get up early, or go to very late and have breakfast late. All these improper timings and inadequate sleep actually puts our it doesn't, it resets our biological sleep clock, which in turn disturbs the hormones in our body, leading to all the lifestyle diseases. Lifestyle diseases like PCOD and diabetes always go hand in hand. So maintain at least 7 hours of continuous sleep. It could be either 10 to 5 or 11 to 6 is the ideal time. Maintain those timings, which helps to keep the hormone levels intact, give us a proper rest to the drugs, and maintains prevent us from getting lifestyle diseases. So culprit number 5 is the sedentary lifestyle. So once you are very much cozy, I mean, you feel that you need to exercise, but you just can't get up. It's a way of practice. The lifestyle, exercise, and diet and sleep. It's a way of how you practice it. So start doing the exercise. You feel good. That is when you sweat, when blood circulation improves, you get a lot of good hormones, the endorphins, good endorphins are released in your body, which helps us to keep us in a very help us to move actively. The brain is very active, and when the brain becomes functionally active, so the hormones come into a normal level, and all the organs start functioning normally. So ovaries also start functioning well, and regular ovulation occurs. So ask them to have at least 40 minutes of daily physical activity, continuous physical activity. Any form of exercise is very important. This is what you have to teach your couple. So once I had seen the 5 culprits of PCOS, and I advised them to go for the right diet, the right exercise. Once they started to follow, they have come into the motivation, they started following this. I feel that they are into the lifestyle modification measures and they started losing weight. Then I put them on drugs. And of course, say no to smoking and alcohol. Then once they are into the lifestyle, then I put them on either insulin sensitizers. If it is obese, PCOS are associated with a impaired glucose tolerance, I put them in metformin, 500 milligram per day, depending on the weight, either twice a day or thrice a day. Or if it is a lean PCOS and no impaired glucose tolerance levels, impaired glucose tolerance, I put them on inositols. These are actually insulin sensitizers. So once you started your right diet and going into the right form of exercise, these two, started along with the diet and exercise, they actually help the ovaries to function, the ovaries start functioning actually. So, and most of the time you do not need induction to the patient. Within 3 months of following the lifestyle measures and the couple taking the metformin or the inositols, they actually start ovulating, and within a period of 6 months, most of them conceive. If it's a young patient with a provided the semen analysis and other parameters are normal, PCOS is the only cause, they started conceiving, you need not also go for the ovulation induction. But doesn't happen to all couple, and not all people follow these lifestyle measures. They're able to follow only 30 to 40% of what we advise. So once I started following, put them on the insulin sensitizers, then we can go for the, if they're not conceived within 3 months of these, then I put them on induction, ovulation induction. As we already seen, and ovulation is the final outcome of all this. So before induction, I make sure that the female, the couple have done some lifestyle modification. Unless they are put on not put lifestyle modification, I do not start on ovulation induction. I always do a second or third day transvaginal ultrasound, because most of them will have a previous cycles unruptured follicles remaining a cyst, which may persist as cyst, that will hinder in our induction. So always do a second or third day transvaginal ultrasound, confirm a diagnosis and see that there's no cyst, then you can start an induction. And day 3 LH, always day 2 or day 3 LH levels in case of luteinizing hormone levels, always maintain below 10 in case of PCOS, and more than 10 in my experience, when the LH levels are persistently more than 10. Most of them do not respond to ovulation, or they have a very thin endometrium, or most of them go for unruptured, LUF, luteinized unruptured follicles. They do not release the oocyte. And even if all this happens, I find that 70 to 80% of them abort before 3 months of consumption. So always try to maintain the LH levels below 10, and a semen analysis should be done. So once we know that only the semen analysis is normal or a mild asthenospermia, you can go for the induction so that once she ovulates, there's chance of getting pregnant. So yeah, is what I said first. Put them on lifestyle modification must be done. Maintain the LH hormone. This we are talking in case of PCOS. So LH levels less than 10. And following this, she should have achieved, so obese PCOS, she should have achieved at least 5 kg of weight loss and reduce the LH hormone. The LH hormone levels gets reduced by lifestyle measures, the high protein diet, high protein, low carbohydrate diet, the insulin sensitizers, and some may need OC pills along with the anti-androgens for 3 months. And very rarely, if it is a very persistently high LH in case of lean PCOD, or if the couple have achieved weight loss, but still the luteinizing hormone levels are too high, more than 15, more than 20, still very resistant ovary, then final option is a lap ovarian drilling. Semen analysis should be done. You keep the male partner normal, find that male partner is normal and keep it aside and check out, always be sure that they have no sexual problems also. There's no erectile dysfunctions or any premature ejaculation associated with sex, and that also should be analyzed earlier. Then you should go for induction. Now, going for the induction, we are not going to talk much theory about induction. So clomiphene, we know the drugs, these are the drugs for inducing ovulation in case of PCOS, the clomiphene, letrozole, anastrozole, and gonadotropins. Just looking into clomiphene. So from which day? We know clomiphene is being, clomiphene and letrozole given right and left to every couple who of PCOS or any other cause. So from which day? So minor points we'll be discussing. From which day? I would like to start my clomiphene very early, around second or within second or third day, not much after fifth day. Now, we know the clomiphene has got a much thinning, it causes a thinner endometrium. So once you start the clomiphene early and you find the thin endometrium long before the time of ovulation, you have time to correct the endometrial thickness. That is why I start the clomiphene earlier. And is there an extended clomiphene? So of course, once we can start with 25 or 50 and previous cycles. If it has got some resistance, you can even start with 100 milligram of clomiphene. So obese patient, I start with 100 milligram of clomiphene. And after 5 days, we go for a day 8, day 9 scans. You don't find the expected size of the follicles. Then after 5 days, I step up to, if I had given 25 milligram or 50 milligram, I step up to 100 milligram for another 3 days. That is how I step up, and even up to 7 to 10 days. If you find some minimal response, you can extend the clomiphene. If you do not want to give gonadotropins, if it is a first cycle or a second cycle, don't want injectables initially, or if it is a non-affordable patient, you can just go with the drugs extended, and there is always an effect with the extended, but still the drawback of thin endometrium is always there, but still there is always some benefit with the extended clomiphene. And how much is the maximum dosage? Maximum, I prefer to give 150 milligrams. Some say it is 200, but 150 milligram could be maximum. If there is no response even with 150 milligram of clomiphene, better we switch on to some other drug rather than giving the clomiphene again and again. So how do we deal with a thin endometrium? As we all know, most at least 50 to 60% of female with given clomiphene, they go for a thin endometrium. Thin endometrium in the sense, I mean, it is less than 7 mm. Sometimes some female with 6 millimeter with a good trilaminar pattern and good vascularity may conceive. And very thin endometrium is considered to be less than 6 mm only. So how do we deal? So that is the first is what we start the clomiphene early. That is the first point. Second is once the follicle, look at the size of the follicle. If the follicle has crossed 14 mm, then it will grow on its own. It is not much dependent on the FSH. Because why? Then you can start with estrogens. Giving estrogens early in the cycle will go and inhibit the feedback effect, negative feedback on the FSH and LH, and suppress the size of the follicle. So once it has crossed 14 or 15, keep it 15 mm, then you can go for estrogens, 2 milligram twice a day or thrice a day. And I also prefer to give it's a very thin endometrium, a combination of amino acid sachets or arginine sachets will also help to increase the nitric oxide synthesis in the endometrium and improve the vascularity and cause thickening of the endometrium. You can also go for a vaginal sildenafil. That also sometimes works. So that is a way. Sometimes even after giving so much of the additional supplements, sometimes some will have a very thin endometrium. And once the endometrium is very much thinned in clomiphene and doesn't respond to any supplement we give, then do not give clomiphene again. Go with other drugs the next cycle, not again, because it again and again the thin endometrium recurs in every cycle. And is LUF, the luteinized unruptured follicle, common? Yes, clomiphene, find few females presenting with luteinized unruptured follicle. What I do is I go for a double dose of HCG, a trigger, or if it is a recurrent LUF, I change the drug. Is luteal phase support necessary? Yes, definitely. And there is a study that the clomiphene causes luteal phase defect. So once the patient is ovulated with clomiphene, the luteal phase should be supported with progesterone, of course. And how many cycles? If everything is going perfectly, that is female is ovulating very well with clomiphene, her endometrium is good, she doesn't have any unruptured follicle, then you can, and the semen is normal, then you can go for maximum of 4 to 6 cycles of clomiphene alone or with the combination of gonadotropins if everything is fine. But once you get a thin endometrium or you get a LUF or there is no response, there's no need to continue with clomiphene, you can change over to letrozole. So what is failure and resistance? Is there a clomiphene failure? Is there a clomiphene resistance? Definitely when clomiphene has failed to ovulate, there's folliculogenesis but failed to ovulate, we call it as a failure. And there's no response to clomiphene. There's no folliculogenesis at all. Even after 3 cycles of giving clomiphene, you call it as a resistance and never give clomiphene again. So letrozole. Letrozole is a wanted drug now for PCOS. Letrozole you can start since there is no worry about the endometrium. Letrozole, you can start it even day 2, day 3, or even after day 5 also it can be started. 2.5 milligram per day itself is enough. We can go with 5 milligram, even up to 7.5 milligram per day. And the follicular monitoring start by day 8 or day 9. And likewise with clomiphene, there is also an extended letrozole. You can give up to 7 to 10 days of letrozole and monitor the follicle if you do not want to add gonadotropins. Or 5 days of letrozole and additional 2 or 3 gonadotropins will help to ovulate. The advantages we know very well. actually there is not much failure or resistance like it was in clomiphene, and it can be started even after day 5, and there's no worry about the thin endometrium or the luteinized unruptured follicles. All the disadvantages of clomiphene have been overcome by letrozole, but straight away you can even start letrozole in case of PCOS. Clomiphene and letrozole, which patient, which to give also. So most, we start with letrozole and the patient has, couple have not conceived, then you can try clomiphene also after 3 cycles. Maximum 6 cycles of letrozole can be given. Gonadotropins, in case of PCO, PCOS, lean PCOS, and the AMH levels more than 6.5 or 7, very much prone for OHSs. Though the incidence is very low, still we have to be very careful with OHSs. The recombinant FSH, the pre-filled recombinant injections is my favorite for PCOS, because I feel this is the best drug for PCOS. It gives the best endometrium, it gives the best follicle, the mono-ovulatory gives the best follicle. It is actually within 7 days of most of them, around 80 to 90%, within 7 to 8 days of giving the gonadotropins, they get the dominant follicle and get very high success rates. It improves the oocyte quality also. The only one which is considered to be a small disadvantage is the cost. It is not affordable to all. Most of them, I keep this as a last resort. When they are affordable, start with the recombinant FSH earlier, but once they find it difficult to pay for this, then slowly we start with clomiphene, letrozole, and finally go with the gonadotropin. Once they failed with gonadotropin, then we go for laparoscopic ovarian drilling. So this is self-administrable. Once taught, even anybody can take it. It's very simple to take this drug, and most of them do not need refrigeration. And it can be, it should be started from day 2, either day 2 to day 5, anytime. And I find this recombinant FSH to be very, very useful, gives a very good success rate, and would like to everyone to try this recombinant FSH to get a mono-ovulatory, very good follicle for conception. Finally, it is the laparoscopic ovarian drilling. I keep this as a last resort for PCOS, and it is not for all PCOS. Lean PCOS with persistently high levels of LH, or obese PCOS who have not reduced, the LH levels have not reduced in spite of lifestyle modification and drugs, or recurrent induction failures, or ovulation, recurrent implantation failures in PCOS, post-natural or post intrauterine immunizations, or very high AMH levels, prone for OHSs when you induce in case of IUI or IVF. All these cases, I would like to go for a laparoscopic ovarian drilling, and it doesn't have a permanent effect. I find that when you follow the lifestyle modification post lap ovarian drilling, you have the benefit for at least 1 year. Otherwise, the benefit is only up to 6 months. And the advantage is that it is a one-time procedure, helps in even resistant cases of very high, the LH levels come down. Very high resistant cases of post-clomiphene or gonadotropins actually respond to lap ovarian drilling. And when they have a normal semen analysis, we find a normal concern, most of them conceiving naturally within 6 months of lap ovarian drilling. and very low. And even if they do not conceive with the ovarian drilling, they have a very low chances for ovarian hyperstimulation syndrome post induction for IUI or IVF. And I keep it as a last. Why is keep it as a last resort? Is the surgery definitely risk of anesthesia and the cost. The cost is also high. And another one is a few couple might go for a reduced ovarian reserve later. That is why you keep it as a last resort, and it doesn't have a permanent effect. That is what you should know. So PCOS, today, looking at the all etiologies of ovulatory dysfunctions, we have just approached how to, we've seen how to approach PCOS, how to start with a lifestyle modification, put them on sensitizers, and then slowly go for the inductions by simple drugs or the recombinant FSH or the drilling. And most of you keep it is a holistic approach, what you're seeing, the diet, exercise, and the drugs, and you go for get a better outcome for PCOS. So this series we complete with PCOS, and next series will be going with the other hormonal causes for ovulatory dysfunction. Thank you.
Thank you, ma'am, for giving all the detailed information with short PPTs, which was in a question form, and you were giving an answer to those questions. Like this was something new format done on this platform. So let me see if we have any queries in the comment section, ma'am. So 1 minute, ma'am. So, ma'am, as you said that the conceiving rate is much less in LOD. So, how much of cases you have found that may have pregnancy success rate from ovarian drilling?
Ovarian drilling, it depends on the couple. So, if the semen is normal, they do not, the tubes are very clear, and they follow the lifestyle measures post lap ovarian drilling also, they have very high chances for conception for 6 months post lap ovarian drilling. Yeah, it's around 30 to 40% the chances.
And then one more question is there, how much chances are there of night sweat symptoms in the PCOS patient? And if they have these symptoms, so what can be done to manage it?
Night sweats are not much common with PCOS. If you go for a poor ovarian reserve because of the low estrogen levels, then you go for the night sweats. So that is how you can differentiate, symptomatically differentiate PCOS poor ovarian reserve. When you go for a premature ovarian failure, that is there also there is ovulation. Here also there is an ovulation, but the difference is that there is the estrogen is very low with the poor ovarian reserve. Those people, the perimenopausal, going for the poor ovarian reserve, go for night sweats.
Ma'am, then the third question is, how do you counsel the adolescent PCOS patient who comes with the complaint of their cosmetic looks, that they have many pimples or very fat in body? Then how do you deal with it?
Nowadays, I see a lot of adolescent PCOS because of, I think, it's our what to say, the study, the system, how the pattern of exams and all that very much stressed when they start the 9th standard, go to the 9th standard, go by 10th, 11th, and 12th. I see a lot of students coming to clinic. This is a new trend now. But most of them are obese, and even the post lockdown, we see a lot of obesity and PCOS because of the sedentary lifestyle, the online classes. They are not able to exercise, and they don't follow the actual diet. They sit in the same place. They do not have any relaxations. So most of them have gone to obesity. So I always suggest the parents to put them on whatever be the class they study, whatever be the schedule, ask them to do some half an hour at least of some physical activity, of at least 20 minutes of skipping or sit downs or sit ups, at least half an hour, and restrict their calorie, put them on plenty of vegetables and fruits, and keep a check on their diet, and see to that they do at least half an hour of exercise. So once they have, I say it's a lifestyle disease. Once they are PCOS, they are lifelong PCOS. It's like diabetes. PCOS and diabetes go hand in hand. When they have resistant PCOD from adolescence, they go for diabetes early. So since lifestyle measures helps in preventing the PCOS as well as in keeping the PCOS under check. You have to put them on. I don't recommend any drug for adolescent PCOS unless they go for heavy bleeds during their cycles. If you have infrequent cycle, or if they have a lot of, the hirsutism, very severe hirsutism, it's a lean PCOD genetic cause, then I will go for drugs. Otherwise, the lifestyle measures will stress.
Thank you for giving all the answers to these questions. And yes, we would like to have more session on such topics. So we will see you on next series episode.
Okay.
Thank you, ma'am.
Thank you for this opportunity given to share these ideas.
Yes, ma'am. Thank you, ma'am.
Thanks, Madam Ganesh. Thank you.
Thank you.